and we can, so far, like almost 40, 50 people mentioned it's almost 50 people, and it's like 75, 25. Depends on the institution you are at. It might be a challenge to be able to dispense this unless you have it in person. I mean, at your institution or at your emergency. Giving the script and then send it to the other places may take some time, and also who cover it, whether work comp versus personnel, and can be like expensive. So I'm gonna move to the next slide. Okay, the next question is, how long does it take you to get the HIV test? Like, can you do it within 6 hours? So you can, so that the test would help you out with it, or does it take you like a day, 2 days, 3 days, or more? And that may help you whether the lab test can tell you if that's easy things to do or not. And this is, of course, we're talking about the source patient, and I would say depends on the source patient's place that could be challenging versus like outpatient clinic, emergency room, or on the floor, or like the needles from the garbage or trash. And so it seems like half of the people are able to take it in the first 6 hours and then like split half. The next question, and I'm taking the first 50 people who vote. The next question is, where do healthcare workers get their first dose of the? And we are assuming that most of us are at the hospital system, but it could be anyone who have it at their work. It seems 1/3 of the people are able to get it at the hospital. I mean, at their clinic. 1/3 in the emergency room, and or the pharmacy, and there's like about 20% in different locations. And it could be a little bit challenge when it goes to a different place. Yes. I'm gonna move to the next question. So, and that's part of the things is like also we learn from you and we share our experience is like, what would you do while you are waiting for the HIV? So that the main reason is for the previous question is like, when you get the HIV, does the HIV testing help you making the decision or not? And whether if you don't have the HIV test, may emphasize that if you don't have the HIV test results, what would you do? Do you start it blindly and immediately, or wait until the source patient's results back? And it looks like 2/3 to 1/3. Now the next question: what do you think the provider, the OEM provider, do when they don't have the HIV? It's not what you think; it's what you think the other your colleague would do. Do they, or in your institution or different institution, do everyone start it immediately without having the result back, or wait a few hours or maybe till next day to get the result back? Seems like people kind of agreeing at the same time. it's like 2/3, 1/3 is they start the medication before getting the result. 1/3 still waiting for the result. And the last question for this session is, what do you think the care workers or the employee would like to do? Do they like to start the medication immediately based on your experience? Do you think they want to wait until the results come back? The reason we ask those three different questions is like looking into different people's perspective, whether you are the employee or the patient versus you are the medical provider. It seems the last three questions is kind of 2/3, 1/3. So just a review for the people who doesn't work a lot with the needle exposure or for the students and new trainees. I want to distinguish two different ones because most of the time we hear in the media HIV PrEP, which is the pre-exposure prophylaxis for HIV. This is not what happens in med clinic usually. It's more than people who want to prevent getting the HIV. It's like general population. They take those medication to protect them from getting, they are high risk or they do high risk, make them vulnerable to the HIV. What we're going to talk about more frequently is the all the time is the HIV PEP, which is called exposure prophylactic. And most of the time, I would say this is an occupational. It can be sometimes general population. I would say we had a case where some of the people at the lab trying to teach each other, which occurs there. It's not technically an occupational exposure. It's like personal. However, we end up also treating them, but it could be both. And it's like giving them antiviral medication to prevent, like to limit the risk of occupational exposure. We worked on this like for the last like about a year and a half. We sent our to the GOEM, and you have something like really recent in August 2025. If you want to read the details, you can scan the barcode. So recently, for the last few years, like we can see, like most of the expertise within occupational medicine, infection medicine, preventive medicine, or all the medicine specialty would agree that it's really recommended to start it within 72 hours and preferred to be started within 2 hours. And depends on where and how you can dispense the medication. That could be a challenge. And the point is to minimize occupational transmissional risk or disease. And data show if people are on those medication, so we all know like needle stick is about 3 per thousand. It is like fluid exposure, it's like 1 per thousand. And then if you use those medication, there's like about 90% reduction of getting those disease, which makes it like in 1 per 50, 70,000. So that's the crucial about, and the more that we read, the higher the risk is. I would tell you in our institution, we have those medication in our cabinets. We can dispense them almost immediately. Also in our emergency room. Typically, we can get the lab, if we have the blood sent to the lab, usually it takes them like an hour to get the HIV result. So we can get it really quickly. The challenge, and we're going to talk more about it, the challenge is if that person's in the emergency, then they're going to move to the floor, then they're going to have a sign, then it's a sign in, sign out, or reaching to the right person to make this order that make it a little bit challenging. Emergency room also can be done quickly. However, like our experience when it occurs outpatient can be a little bit challenged. I would tell you most of the time we can't get the lab result when it's outpatient clinic. And I'm not sure why, whether the sort of person would come back to the place or it's hard for the clinic to obtain them. Most of the places we can start it in our institution in the clinic or the ER. So the question here is, should we really adhere to the guidelines when we don't have the lab results and give maximum occupational, reduce the maximum, minimize the maximum occupational transmission risk versus sometimes the healthcare worker or the employee doesn't want to start the medication without confirmation. And some of them, they are anxious when they read the side effect of the medication. And this is really a long list of side effects. So we'd like always to answer the question, is it whether it's yes or no, whether it's true positive versus true negative when the real life is false positive or false negative. What I mean is, like, would you give the medication without knowing, and then the result would come back negative, and you would have like a side effect of medication, versus you say, well, it's 1 per 50,000. I'm not going to give the medication, and of course that time the result would come back positive. So we are in those like two type of error for people from NPH or public health, error commission versus type 2 omission, for alpha versus beta. And I would tell you, usually it's easy when you have the result and you can start it. Those are the questions that we ask. I would tell you, majority of med providers would start the medication without getting the result, and the data showed the way that you voted. And comparing to the employee or employer, there's some percentage that they don't want to start the medication. Some of them, they like it immediately, but some of them, they want to know the result before it. And at least that's my experience and my colleagues' experience about it. And we mentioned we can, in our institution, we can dispense it in the site. Okay. What's the challenge to get the lab result within let's say 4 hours? One of them depends on where you live. It could be like the consent. Some places may still need like HIV consent. In where I work in Philadelphia, you have to have both the source patient and the healthcare workers consent for it, even like verbally. Some people verbally write or written. The availability of the phlebotomy. Sometimes I've seen it where people wait until the phlebotomist come and take the blood, and that could be, if the injury occurs like 7 p.m., could be the next shift in the morning, or takes like several hours. Or they may send them to the lab, and the lab is closed versus it's busy. The other thing is, if it occurs in the clinic and outpatient clinic, and I would tell you that's, at least for my experiences, that can be very challenged to get those lab results done immediately. And sometimes I'm sure like your employee would ask you what's the side effect, and I always start, it's almost anything. You can name it, you'll have it with those medication. Now it could be very, very minimal, but you could have nausea, vomiting, diarrhea, constipation, fatigue, fever, weight loss, different thing. And although it's not very common, it can happen. I can remember like 1 or 2 cases where it was really devastating. One of them is like our OR nurse. She had very severe diarrhea that she could not scrub. She had to go to the restroom every like 10, 15 minutes. And I had to call the manager, and initially the first question is like, can she not scrub? And immediately they like everyone to be in the OR room. but luckily they were able to accommodate her for those 28 days. So the option is usually either start them immediately or not start them. Or what we kind of thought about is like maybe the third option is wait for the results or give them those medication and let them have this 1 day worth of medication. Depends on medication that you dispense. It's usually like 3 pills. And they take it over 24 hours. If it's Friday afternoon, and we see a lot of people on Friday afternoon, we'll give them like 3 days worth of medication. They have those medication. Usually it's like an ER nurse or somebody in the floor that they injured, and they have those medication. Those are their patients, and they can check the result frequently. And usually, once the result is back, they would start the medication, or also we give them the chance to think about it and make this decision without having to make it while they are in the clinic. So that would help them start the medication once the result is back and without the pressure being at the clinic. And looking into this option that having the medication in your hand and decide to take it maybe half an hour or an hour later, it's first of all, you have the access to the medication, which is give like do good. It's not giving them the medication when in a couple of hours the result going to be negative, which do no harm, and also enable them with informed choice. I would tell you a lot of them appreciate it. A lot of them, they don't want to take the medication if they don't have positive test. And also they give them a good counseling about the risk and benefit. And they appreciate maintaining autonomy. Now, yes, there's people who want to take it immediately without getting the result, and even if the result is negative, and that's okay. I'm just thinking about certain people who would like to take the medication when the result is back. I'm gonna do a shift for like the other mini lecture, and we're gonna do a couple of questions. So we here also we're still talking about the needle stick and bloodborne pathogen. If you like recently in 2020, we have like new guidelines for the needle stick or bloodborne pathogen, and I want to ask you, which one do you think CDC would do or recommend doing? Hepatitis C RNA, hepatitis like doing the RNA, doing the antibody, doing both, or doing neither? I mean, a couple of more people to be 50. Okay. Most of us decide that they want to do hepatitis C virus antibody. Some of us would like to do, do the reflex, so antibody, then you do the RNA versus the RNA, and only like 15% decide about both of them. Um, um, which one is the preferred one? most of people who are routine, they want to do the antibody first, then they do the and do the reflex. Um, and this is my other question, and this is for us also to learn from you. How long does it take your institution to get the hepatitis C RNA? I'm not talking about just the antibody. I'm talking about only the RNA. If you order the RNA, how fast can you get it if you only do RNA? I will tell you, most of the time, antibody can, at least in our institution, can come quite fast when you do the antibody. And it's interesting to look at the bottom two is to see like very few people can get the result kind of immediately for the RNA, and 10% cannot get it within 72 hours. Majority can get it within 24 to 72 hours. And part of the reason of the question is kind of the hepatitis C RNA is not available when you cancel the person if they come from emergency room or from the floor. So CDC recommend both of them you can use. So I know the majority of you choose one and choose the anti-hepatitis C virus reflex. However, actually the recommendation is that you can both use either that one or the second one. Which one is preferred? Actually, the one preferred is the RNA, not the antibody. So it's kind of opposite to the majority of the people who voted. Otherwise, in our institution, I would say it's kind of similar. It takes a couple of like between 20 to 72 hours to get the hepatitis C virus. You know, like, or how much would it cost to order either one? I've tried to make like it is difficult when to get those information, especially with different health insurance and different things. But usually, doing the RNA is almost like a double. Doing the reflex, yeah. Without having the insurance, it's usually labeled as like almost 800 versus 400. Now, not including like what's covered by insurance, but at least what people like immediate charge for. As I mentioned, the RNA is the number one. It's the preferred by the CDC. In our institution, I was reviewing the needle stick with our team, and I've noticed like we do both tests at the same time, continuously, and I find it interesting to look into those things. And also, one of our nurse practitioner mentioned that sometimes you can get RNA positive without having hepatitis C positive, which the first time I've heard it was like a little bit shocking. So we went over as the team, and we went over it and looked into the results and reviewed everything that we have. So we had about we started about like 1,500 cases, and after like kind of double checking the results and double checking the issues, we end up like about 1,200 people, and we didn't. We went back for the last almost 2 years and a half. We have two major hospitals that we reviewed them. They use the same lab, and we looked at the people who has tested for RNA for hepatitis C virus and also for those antibody. We looked to different numbers, then we removed the cases that are either replicated or it's not blood fluid exposure, and that's kind of the number that we went through. Interesting, we found that we have like almost 5 cases where the antibody were negative, non-reactive. However, the RNA was detectable. Now, most of you either do one of these. So if you have the RNA, you don't test for the antibody, or if you have the antibody negative, the reflex would not work. It wasn't really high numbers. It would say like almost half. However, most of them were in one institution, facility, which makes it almost like 1.4. I don't want to go through the details, but at least I will tell you one case was like really big, significant. And we looked into if they have other reasons, like other autoimmune disease, other issues, and we could not really find like a specific. Now, it's still work on progress, but just I want to kind of bring to your attention that number one is better to do the RNA. That's kind of the CDC recommendation. It's increased the accuracy of your results. It is more expensive, and the issue with it is like you can't get the time result a little bit longer. If you do the hepatitis C virus, I would say you may have very, very minimal amounts of people that you may miss. We still working on it, so to have like really definitive answer for it, but we support what the CDC saying. The good things about the antibody is that you can get it really fast, usually within a couple of hours. I have like a survey if people are able to go over it, and I'm gonna open it for question. And if somebody would like to talk about.
Good, Marianne, did you change the procedures then at the hospitals that you work with so that they're only doing the RNA test? Because it seems like you wouldn't. What would you do differently with the antibody? Didn't give you any really additional information. It just maybe gave you a little bit early information.
So most of the time, it will help you. Like if it is negative, it tells you that it's negative. However, there is just to be aware that sometimes it could be negative, but you could have 5 cases out of 1,000 that the RNA is positive, where the antibody is negative.
I know, but what's the value of doing both tests? Do you think that seems like it's double expense, and you're not getting anything really additional out of the antibody test except for an earlier indication? Or did you change the protocol so it's just doing the RNA, or are people still doing both?
So it's the RNA, as you said, the RNA is much better. The problem with the RNA is when you put the order for the RNA, most of the results come back to the source patient, to the provider's order, and you don't get the result back from them unless you look at it. And most of the results come back a couple of days later. So unless you have a system mechanism that you check for them a few days later, a lot of times people may miss that. So you would get the RNA in 3-4 days. The person is not you are not seeing that person, the lab does not come back to you. You have to have a team who reviewing those on a daily basis and making sure. And that's what we kind of did with our nurse case managers, is like kind of going back case by case, making sure that we are not missing on any of those.
Thank you for the presentation of the plan. That was part of my questions that I wanted to ask. I work with MPKIM over there, and this is one of the problems we face as well, getting results back on time. So when you reviewed, because it looks like you did a retroactive look at all your data. So for the 5 people that had the positive HCV RNA test, right? These are the source patients, right? So what did you do for the exposures? Because for them, for our patients, right, even if the source is positive, then you just monitor, right? Until if you find something, then the recommendation is jump on the treatment right away.
And that's part of the problem, is that the source patient is not your patient technically, and you can't put the orders on them, or you can do it like a brief time. However, you take care of the healthcare workers, and that's part of the challenge, is that you want to monitor the source patient. I mean, the source patient, you want to make sure that are they treated? Is this like, I would say 5 of those cases, only one was really significant. 2 of them were like kind of detected time. We tried to, so what you do is you repeat the test for them as like regular. The problem with having only the antibody, your antibody is negative. So you're gonna tell them, okay, your antibody is negative. You don't need to be tested. What we recommend is like keep doing the test, or getting like an RNA negative for the source, which also you have to manage that with other providers. Some of them are in the ER, so they don't have a provider. So that makes it a little bit challenging.
Right, and then just quick follow-up for so I'm assuming with looking at the HIV data that you presented, then you changed your approach at your institution to just making the PEP available to the healthcare worker, and then they get to decide if they're gonna take it or not, whether wait for the results to come back or not. So how do you manage the follow-up for that? Like, you give them the 1 pill or 3 pills, and then you see them. How quickly are you seeing them back? And do you guys go ahead and give them the full 30 days? At our institution, we give them the whole 30 pills, and there is a lot of waste, because then we get the result back, and it's negative, and pharmacy is not going to take it back. Right, so that's
a smart question. And if you look at the price, and also I looked at the price, it costs about like $1,000. Depends on the medication. It costs like about $1 to $2 of medication. And luckily, most of our team are here, providers, nurses, and case manager. So what we do is we give them a worth of 1 day versus 3 days of medication, and by that time we have a team that we have people on call reviewing those lab results on a daily basis. If the results come back positive, we tell them, come back, we'll give you the entire script. So they come the next day, when they go to the emergency room, they get the full script. If the results come back negative, we tell them, if they are using the first 2 pills, don't take the next one, you don't need it. And that way we technically give them only 1 day of worth of medication. You need to study how much you give full dose versus others, but the cost of the full dose is not cheap and not very available.
Congratulations from Johns Hopkins. I've been managing the STIX program for Johns Hopkins for the last 20 years. So with our HIV or PEP exposure team, what we do is we give, on a weekend, we give 3 days. Our on-call prescribed 3 days to get to our clinic the next business day. when they come to our clinic, we give them a 5-day supply so that if they tolerate the medications, then we give the next succeeding supplies to get them for 2 weeks because they have to come back within 2 weeks to get their blood done. So we will not be wasting medications. Because if they don't tolerate the first 3 doses, then you need to change your cocktail. So that's one. Number 2, regarding our follow-up with HCV, if we know that the source patient is HCV positive, our employees are tested for HCV RNA for 6 weeks and 4 months. If those are negative, then they are done. With the last 20 years that I had at Hopkins, I only have 3 cases who seroconverted to HCV. And the seroconversion takes place within 3 months. That the employee is seroconverted because their LFTs goes up. And so we check their RNA and they're positive. So that's the time when our employees get referred to our ID.
Do you do antibody or RNA?
On the first baseline for our employees, we do the antibodies. On the 6 weeks follow-up, we do the RNA, and then the fourth month follow-up, we do the RNA. If those are negative, that means to say that our employees are safe. Even the source patient is non-HCV positive. So that's how we handle at Hopkins. We have a smooth operation because we have infectious disease that help us with our PEP.
Thank you.
Thank you for your excellent talk. When you did your calculations of, quote, more expensive, did you factor in the cost of treating the disease, the legal cost of detecting the disease, and all that?
Dr. Carl asking like really important question. It was, I tried to work on the emergency side as well as like just what's caused, and I will tell you it wasn't easy to get a lot of information. So those are just based on what the lab would charge immediately without any insurance. Now, putting insurance, putting doctor visits, putting other stuff would change the game. And it could be like, the insurance would knock it down to 90% or 95%. And whether it's like a regular insurance versus work comp insurance, what I want to just give an estimate is like RNA at least double the price of antibody.
But beyond the testing itself, there are costs.
Oh,
in this case.
Yeah, we didn't go beyond that.
Hi, Maria Lonzi, Philadelphia VA. Thank you very much for your presentation. We did similar processes around the same time in 2018. And so we do on every source patient does get a Hep C, as well as Hep C viral load, separate draw. And our population is of course unique. We have approximately 30% of our population is Hep C positive to start out with. So we already knew that coming into this that we needed to address the possibility of the 9-day window between having an RNA positive and an antibody turning positive. So that's issue number 1. Issue number 2, we instituted shared decision making. So when we've been able to work with our lab so that we have a stat result within an hour, and we have actual data that shows that.
Result of which lab?
Source blood comes back to us with HIV, comes back to us within an hour. Hep C, the antibody will come back to us within like 2 hours. The RNA will come back to us within about 3 days. But we have shared decision making for HIV PEP. And as far as Hep C goes, we also have not seen anyone seroconvert to Hep C. We are very fortunate. We work very closely with ID, knowing full well that about 25% of Hep C cases will self-clear the virus. And again, in the VA, we're very fortunate. We have almost wonderful experts that we can refer to. So we do monitor our employees, post-sticks, and we do the same thing. We do not enter orders on the source patients. That is entered by the source's clinician. We do monitor them on our end, and we have a specific nurse assigned to do that on a daily basis to go back and look at their labs. And we follow our patients at 3 weeks, 6 weeks, and 3 months.
And when you say hepatitis C, which one do you do? Do you do antibody and
RNA. Yeah, we do both.
And is this just for your institution? Or is this like why? Like
Actually, when we designed the model, it became a best practice, so now it's a national model.
So you recommend both of them?
Yeah.
Okay. Thank you very
And
much.
it's just because of the way it works for the lab testing. We would never just go an RNA without doing that because see on the initial screen, we can give an RNA individually, but that's when, God forbid, we're following one part. It's not necessarily.
Just want to say thank you very much.